vaka üzerinden değerlendireceğiz ve birlikte tartışacağız. Toplantı sırasında, vaka sunumu sırasında lütfen sorularınızı sorun ve sorularınızla birlikte biz vaka sunumunu keserek tartışmaya devam edeceğiz. O yüzden sunum sırasında da sorularınızı bekliyoruz. Bu sorularınızı da ben hem prezenterlara hem de kendim prezenterlara yöneteceğim ve bu şekilde de tartışmayı daha interaktif hale getireceğiz. Welcome to my friends and welcome all the attendees. This is the webinar of Cardio ABC Intervention. It's a great pleasure. I would like to introduce my dear friends and expert operators of complex PCI procedures. The Kambis Mashayeki from Germany. You know him from our CTO meetings. He attended and contributed a lot to our CTO meeting. I would like to thank you to him. And the second friend also from Italy, Gabriella Gasparini. He's from Milano. He's also expert on the CTO and the complex PCI. And also we are familiar to him from many meetings, international meetings, live transmissions. And also as a Turkish colleague, we know him last 2 years, the big contribution, both Kambis and Gabriella, to our Istanbul CTO meeting. And I would like to thank you, both of them, for their contribution and attendance for the meeting. And also would like to welcome to everybody for the meeting. So now the program is, as you can see, that including some complex procedures, the complex CTO procedures, and the DK crash procedures, and some rotablators. The objectives of this webinar is principle and sequence of the DK crash technique, learn some tips and tricks of the left main stenting complication management, which can happen most of the time when you are dealing with the complex procedures, and complex CTO treatment case presentation, and the lesion preparation with the rotablator. So, first of all, I would like to give words to my colleagues, and then I will do the first presentation as a host, and then we can continue to discuss. And okay, the floor is yours, Kambis.
Yeah, thank you very much, Mustafa, for this kind invitation to the webinar. So I think we went all through a tough time. Probably the most was for Gabriele in Italy. And I think it's a very interesting and a new aspect that we can meet each other, very simple, and also can share education based on this new platform, which makes the, well, let's say, new area of digital communication. So, and yeah, so I think it's very useful, and I'm happy to be part of this webinar today.
Okay, thank you. Gabriella.
Okay. Good afternoon, everybody. Thank you very much, Muzaffar, for this kind invitation. I'm honored to be part of this educational project. And I think that all of you knows that we are moving to a new era due to the COVID pandemic. And we should be able to use and become friendly with this new educational format using this platform. So it could be very useful for all the interventional cardiologists to attend this kind of meeting, such as yours meeting. Thank you very much.
Okay, thank you, friends. Now I'm going to start the presentation. The title, the case-based step-by-step DK crash technique bifurcation, and the case is including rotablator and RCA CTO. So the case is male, 71-year-old, the recent class 3 angina. Risk factor is hypertension, type 2 diabetes, and dyslipidemia. And ejection fraction is good, and he has a normal kidney function. And as the patient referred to our hospital, as you appreciate, then the patient have a Medina 111 classification, the proximal LAD and diagonal bifurcation lesion. And the angiography, the baseline angiography performed in another center. And you can see that the occluded to the RCA and the retrograde flow to the RCA from circ mostly. and then look at the RCA with some retrograde flow from the left system, as you can see from the angiography. So what will be the strategy for this case? Just I would like to start in this case, what we should do for this case. What will be your approach, Gabriela?
Yeah, I think that in this case, if we plan LAD stenting, we can use even radial access, and depending on the operator discretion, we can use 7 or even 6 French, because most of the 2-stent technique, such as the K-crash, could be performed using even 6 French. And then obviously, in case of failure of predilatation with a balloon, the rotablator is mandatory. In this case, sometimes you should perform it even after good dilatation in order to prepare the lesion in the best way before stenting. Okay.
The Cambis, your comment?
Well, the point is here, whenever you have high-grade stenosis on the donor vessel, the LAD, I'm always thinking, if I have any chance to open the vessel antegrade first, the CTO, to reduce the risk on the donor vessel. But here I think it's very difficult, because it is really a relatively long occlusion, and the probability to get an antegrade, the CTO recanalized by antegrade approach is probably low. So therefore, you have to go for the LAD first, and then maybe be ready for the retrograde access. So now the question is, when you go for the LAD first, what strategy is safer? The sole angioplasty and then stenting, but there you have the bifurcation with the diagonal. So I don't see too much calcium. I'm not sure if I would directly go for rota initially, even if I'm doing a lot. Probably I would try just to do a conventional angioplasty on the LAD diagonal bifurcation, and I would also go with 7 French.
Okay, I think this case also including some lessons which you contribute, like Cambis, from which lesion we have to start. Okay, but for this time we have to also evaluate. Then I will show you during the case presentation. We have to evaluate all the lesions properly in order to find the correct way. Okay, so let me start. So our strategy at the beginning, just treating the parent vessel, like the left system, then continue to the RCA CTO. The lesion was very calcified. Then because of that, so maybe the possibility to turn to, or using the rotablator, we choose this 7 French guiding catheter. This is our during the procedure angiography. As you can see, we use the 7 French radial access at the beginning for the left system. Okay, so you can see the retrograde flow, and the first we just attempt the balloon predilatation, but we failed the balloon dilatation, although we just go to the 24 atmosphere high pressure several times, and almost more than 1 minute, 2 minutes we just waited for the dilatation, the lesion, but we could not successfully dilate the lesion. Then we have to turn to the rotablator for the lesion preparation. What we have done, because the lesion was very long and there are the consecutive lesions, severe stenosis, one mostly located in the bifurcation area, and the other one is the mostly middle AD. So then we do the rotablator on the left side in the proximal part and go more distally, and we use 1.5 millimeter, 125 millimeter Rotalink rotablator. Of course, during the rotablator, we remove the wire of the the both wire and we put the rotor wire and we remove the diagonal wires. Then we did the pre-dilatation for the all LAD lesion and the LAD and the diagonal lesion and the bifurcation with 2.520 millimeter NC balloon. Then we successfully dilated the lesion. Then we put, of course, for the DK crash procedures, first we put the stent to the diagonal, and of course for the crashing we should keep another balloon for the crashing the proximal part of the main vessel. So of course after dilating the diagonal, and then we crash the diagonal stent. But as you can see, the most of the time, I will come back. Okay, here. Then when we inflate, we put the stent to the diagonal and the parent vessel, and I remove a little bit the balloon again, and going to the higher pressure, which is including the more proximal part of the LAD and the most part of the diagonal. And at this time, I prefer in order to avoid this distal dissection to the diagonal branch, I partly removing taking the balloon to more proximal and going to the higher pressure. Then I am crashing the lesion. But here we did partly a mistake because we keep the wire in the diagonal branch. So is it mistake, or we should sometimes can keep the wire inside the diagonal? What about your comment, Gabriela?
Okay, generally before crashing the stent, I prefer to remove the wire into the side branch, but this is my preference. Okay. There are different opinions.
Yes, some people are just keeping the wire in order to guidance for the next the following the procedures and rewiring. But mostly I remove. But in this case, we kept the wire in the stented in the diagonal, and then we crashed. Of course, then we remove the wire.
No, I have another. Can you hear me? Yeah. Yeah. Okay, I have another suggestion. It seems that there are some under-expansion of the proximal part of the side branch stent. So in this case, I prefer, before doing the crashing, to post-dilate the side branch stent, because sometimes it could be difficult to advance a non-compliant balloon into the crushed struts of the stent. But it's okay. This is another my preference. When I realize that there is some under expansion of the side branch stent before crashing, I prefer to post dilate it.
Yes, yes. This is what I explained at the beginning. So when we put the stent balloon, we remove a little bit more proximally and going to the higher atmosphere. So in this case, we put the stent at the beginning 12 atmosphere, and then I partly remove so I have this image. Then I partly remove the balloon of the stent. Then I go to the higher atmosphere. Then I have more expansion in the proximal part and the bifurcation part of the diagonal. Then we should. I'm going to crash the lesion. Then at this time, so it's possible to cover all this diagonal orifice with the stented segment. And then doing the rewiring and the first kiss is getting more easier in this situation. Okay, then we do so. Then we are rewiring the proximal part of the diagonal, and we perform the first kiss with 2.75 balloon for the diagonal and a 3.15 millimeter balloon for the LAD. So after crashing, then we put the stent from the distal part of the LAD the first one, and the second one, which is overlapping the distal LAD stand, we put the other one to the LAD, and we crash. We put the stent to the LAD, proximal part of the LAD, and after that, just also we prefer, of course, crossing the diagonal stent from the proximal cells. So in order to make the second keys, we just cross again the diagonal and the stent after stenting the proximal LAD. And at this time, we also have problem, as you mentioned, Gabriella, we had a problem with the proximal part of the diagonal. We have to do the more, a little bit more predilatation for the proximal part, proximal cells of the diagonal part. Then we perform the kissing. So the diagonal second kiss, and then we perform the post dilatation, and we finalize the case, the pot to the most proximal part of the LAD with 3.5 8 millimeters NC balloon. Then we have this final results with the diagonal and the LAD. Okay, what about your comments for this one so far?
Well, Mustafa, I think it was a great result. So what I would suggest in generally is, if you don't have the scenario of an uncrossable lesion, you go for rotablator. I think once you decide for rotablation and you have a vessel diameter here like 3.0 and the side branch also at least 3.0, I think you can take a bigger burr.
Yeah.
Because it's an investment. So therefore, you can go with a 1.75 or 1.5. The only concern would be maybe the bigger burr result in more slow flow. So therefore, you have to go with shorter runs and that's a little bit shorter runs and give a little bit atropine in front. The 1.25 burr here is not so efficient. You could see it on the diagonal that you had a problem with the angioplasty, and also some eccentric calcification still remained on the mid part of LAD. So this is one thing. Another is that here I heard a comment in the chat about somebody who asked, did the patient refuse CABG? And I want to comment on this because it's also very important to understand. I think the question is not if the patient refused CABG, the question is, did the interventionalist offered PCI? Because if the interventionist offers you a PCI, you would take the PCI. It's not that it's not written that the indication for PCI is that you have to refuse CABG, right? It is only if you have a 3C indication, which is a syntax score, which is much higher than 32. So therefore, I don't think that this patient is primarily just has to go for CABG. And the reason why people are asking this is because they see the CTO and they're not able to treat it. So therefore, my suggestion would be that you ask really seriously the patient if this patient wants to have PCI, and then you contact somebody who is able to treat it. I think it's a reasonable approach.
Okay, so at the beginning of my presentation, I thought that this presentation is including some lessons. So I deliberately didn't mention the size. You are right, because at that time we have only available 125 rota, and so that this is why we use the 125. So I personally prefer 1.5, but we were 2.0, and I'm really afraid of using 2.0 because I really look for the bigger vessels and then the no reflow risk. So I prefer, instead of using the 2, I prefer the 125. So this is the reason. So thank you for your comment. So you are right, but we used 125, and you are right. And we had, maybe if we used the bigger rota, maybe we could have bigger, better stent expansion. But at the end, so we had a good stent expansion, and also we haven't any problem for the peridilatation of the lesion. So then,
and Dr. Dergi, we have one more question from the audience. That is it advisable to first go for the RCA, CTO, or LAD bifurcation?
Okay, so now after showing my dual injection, then this will give us answer, and we can continue the discussion. Okay.
Okay.
So on the right hand, you can see. So first, I will touch on the right hand. This is the baseline angiography which the patient referred us. So when we saw this one, then we started first to the left system. But after performing the left, look at the lesion. This is very short lesion, or short CTO lesion on the RCA. If we did maybe the dual injection at the beginning of the procedure, then maybe we are going to treat the RCA first. How about your opinion, Gabriela?
Yeah, Muzafer, can you show us the first diagnostic exam that was performed in another hospital? Because just to have an idea if it was predictable to understand the length of the lesion or not. Because obviously, if we look the dual injection, we can expect that we can go antegradally without maybe too much difficulty. But maybe if you plan your strategy on your first diagnostic exam, the information could have been different. So
okay, I will show you.
If you can go back to the first.
Yeah.
Because in this case, the strategy that was suggested by Cambis could be the most useful or safer, because you can reopen the right coronary artery antegradally, and then you can work on the left system without the support of the collateral coming from RCA. Coming from reopening RCA.
Can you see now the baseline?
This is not really a good exam performed just to understand the CTO.
Yeah, the other one is like this. These are all available angiography of this case. And this one on the right side, very short rounds, but maybe here, when we look at detail here, up on the right side, we can see more information here, just showing some short distance of the occlusion, maybe.
Yes.
Okay, I think this is the importance of the pre-procedure evaluation. Maybe even in this case, we have to do this. Before starting the procedure, we have to do the dual injection, and then just continue and define the strategy first. But we just started with the left system. Okay, let's go further. Then for the RCA, just we started with the 7 French guiding catheter. I will come. Okay, this is the angiography. And after having this angiography, then we continue. First, we just, as you can see, the proximal cap, we have some resistance on the proximal cap. First, we tried with the Wildrix TR, but just we could not cross. And then I will turn to the Gaia second, then easily cross the lesion. Then remaining is, of course, the standard lesion. Then we just make peridilatation and put 2 stents over there. Then this is the final result of the RCA and the LAD. And in the mid LAD, of course, we have some still existing calcification and the effect of calcification in the mid part of the LAD. If we could go the bigger rota, maybe we could have more expansion, but so the stent is 3.0 and I put a 2.5 balloon, almost 20 atmosphere for the post dilatation. And the final results as like for us acceptable, and we now just we finalize the case with these results. And briefly, okay, so when we look at the two-stent strategy, if we have a true bifurcation lesions from Euro bifurcation club definition, so the major concern regarding the side branch and the main branch stenting, so that we should prefer, they suggest the DK crash. And so when we look at the steps briefly, so we have to put the stent first on the diagonal, and then we should crash, then rewiring, then doing the kissing balloon. And after that, at this time, it's important, the pot is important here, both in the procedure, in the side branch stenting, and even at the end of the procedure, after putting all the stents, also performing the pot, the proximal part of the vessel, the main parent vessel, is important for the providing the good float dynamics and for the longer term success. Okay, thank you for your attention. And do you have some questions and comments, Göksel? So I cannot see now properly. So what about questions?
So there are several questions. So first is, would you go first to the RCA CTO or LAD? That was the one.
Okay.
We discussed this already, right?
We already discussed this one.
Another one is CTO score is not so high for RCA.
Yes, it's true.
And one more, and it's while wrestling with the double kissing crash, wire passage to the side branch turns intimal struggle. So what should be done to overcome with it?
And one more question: what is your second option for crossing RCA CTO instead of Gaia second wire? So what will be your approach, Kambis, for this case? So what about your wire escalation for this case?
Well, my daily routine, I try, like you, to start with a filter XT, XTR with a polymer jagged wire. And if this fails because of calcium, I just step up to Gaia third. So, sorry, Gaia 3 or Confianza. And because just to save time, right? I'm doing this every day now, and therefore I step up very, very fast. So, and if antegrade finally fails, we have beautiful retrograde options. The over the septal, but also the circ epicardial. So one question I would ask you is about the bifurcation strategy. So here we are going for DK crash, but this is still also a case which can be done by culotte. And at least we don't know the answer, what is the better. So in my daily practice, if I have the chance to make a culotte, I'm going for the culotte because it's easier, right, and faster. And I think the result is not bad. So at the moment, we don't have clear data in non-bifurcation lesions, which is the better strategy, the DK crash or culotte. So therefore, actually, we're running the BBK3 trial here in our center in Bad Krozingen, multi-center trial where we are going to compare DK crash versus culotte in non-bifurcation lesions, non-left main bifurcation lesions. I think it's an important trial.
I think, yeah, that's true. Most of the time, the operator experience is important. You know that. Because the DK crash is really, for me, it's more time consuming and more material you requiring compared with the provisional stenting. And but if for this case, the vessel size is also is also convenient for choosing the culot, because the diagonal is 275, so you can go even 3, and for the LAD you can choose 3 or 3.5. So it's also possible to do to perform for this case the culot. So actually getting more experience with DK crash, and the results of the DK crash, of course, although we haven't a study just which is comparing really culot and DK crash, the DK crash is superior for the provisional stenting from the left main studies. We know that now we have some we are getting more experience with the DK crash, but it is really requiring more attention while crossing and using the technique, the balloon and the pot. We have to pay attention to all those things.
Kambis, your consideration about the choice between culot and DK crash is for non-left main bifurcation or also for left main bifurcation? I mean,
well, it's a little bit difficult because for the left main bifurcation, we have already a randomized trial out where we know that there is a superior for left main in the DK crash. Even if this trial is an Asian trial, and so from China, and I at least I know that the percentage of the dual lumen microcatheter from this trial was very high, up to 90% was used. So therefore, because there are several problems on the DK crash, right? The first is if you are not doing an adequate pot and you are not crushing completely. So then you may go with your wire, with your rewiring beneath the struts. And once you get then you want to push a balloon and then you crush the stent and you get a concertina in the crushed stent. So there are really some steps which are complicated for the normal PCI operator. And I don't say for people who are doing everyday high complex PCI. And this is a little bit my concern of the DK crash. So once you use a dual lumen microcatheter, you are relatively sure that there's at least your second wire, even if you are not have the best crash, and you learn in a good technique with the dual lumen, you're sure that you can rewire without getting the stand wired in front, right? So, but it's this has the disadvantage of a higher economic cost. So. Therefore, at the moment, I'm not sure, and we will see what the PBK3 trial will show, and which is the superior technique at the end of the day in Europe for non-left main bifurcation. Right?
Okay, thank you. So now I would like to just give the screen my friend Gabriella. Because we would like to, maybe we have to discuss more the DK crash and the application of DK crash on the left main. Are you ready, Gabriella?
Okay.
Okay. The floor is yours.
Okay, thank you. Okay. Okay, can you see the screen?
Yes.
Okay, great. So, the topic of my presentation is unprotected left main PCI with RCA CTO that was treated using DK crash, and then we had the complication that we had to manage. So we can go into the presentation. We are talking about 60 years old man with a history of hypertension, dyslipidemia, and previous smoke, with a previous history of a non-ST elevation myocardial infarction that was treated by PCI with stent implantation 5 years ago. And then 2 years later, he experienced an effort angina, so underwent a new coronarography that showed instant restenosis of the RCA that was treated with the PCI and DES in DES. He was he was admitted to Howard Hospital a few weeks ago with a history of effort angina. He underwent to clopidogrel therapy the day before the procedure, and this was the angiographic finding. So we are in front of a new restenosis, a total occlusion instant CTO. And as I said just a few seconds ago, we are in front of a CTO that was previously treated with S-index. So thinking about the opportunity to reopen this instant CTO is debatable. So, and this is the left system, and you can see that there was a left main distal disease involving the bifurcation, the ostium of the circumflex, and the ostium of the LAD, and there's some moderate disease of the mid part of the LAD. Okay, this is the cranial view. You can see the distal involvement of the left main, and this is the spider view, when we can see the ostium of the circ that was involved by the disease. So if we consider this kind of lesion, we are in front of true bifurcation lesion. This is a Medina 111 lesion. So we have to evaluate the best strategy. We are talking about an unprotected left main lesion with concomitant RCA CTO. And the lesion was obviously angiographically significant, so we have to evaluate what could be the best strategy for this patient. And in terms of revascularization, we have to evaluate the difficulty to achieve a long-term patency of the RCA if we treat to reopen this instant chronic total occlusion. So in this case, we discussed with the patient the opportunity to undergo the surgery because of the opportunity to achieve a complete revascularization. And for this reason, we calculate the CINTA score that was 27. And we called for the surgeon that came into the cath lab. We discussed quickly together, but finally the patient refused the surgery. So we went on with the PCI. And in this case, we have to plan the strategy in terms of treatment of left main lesion. We are in front of a true bifurcation lesion. So finally, we decided to perform a EK crash, like in this algorithm. And then in my opinion, but it's debatable and we can discuss, in my opinion, in the left main bifurcation lesion, I prefer to perform systematically DK crash. So this was my strategy after obviously a prior dilatation of both lesion, the circumflex lesion and the LAD lesion. I advanced at 3.028 drug-eluting stent into the circ, and then I crashed the stent, as you can see in this angio, I hope. Okay, this is not really important because it's just the advancement deployment of the stent, the balloon to perform the crash. And then I inflate the balloon after removing the wire into the circ. As I said before, I prefer to remove the wire before crashing the stent in order to avoid wire entrapment into the side branch. And then I perform the first kissing balloon. And I did angiographic check. And as you can see here, there is some underexpansion of the proximal part of the stent into the circ. So before deploying the second stent into the main vessel, I decided to post-dilate with a 3.25-15 non-compliant balloon to the stent into the circ. And I tried to advance the second stent into the main vessel, but as you can see, I have some problem to advance, some resistance, maybe some slight calcification. So to avoid this problem of lack of support, the setting was by right radial with 6 French guiding catheter. Okay, I forgot to say this. So I decided to improve my support using the guide liner. So this is a guiding catheter extension. It was very easy and quick to advance. And then I was able to deliver the second stent into the main vessel. That was a 3.5 24 drug-eluting stent. This is the result after the deployment of the second stent. And I performed the first pot, as you can see here. And then the next step should have been final kissing balloon and the final pot. But something went wrong because after main vessel stent delivery, there was some instant miscellaneous. You can see, I hope that the image could be enough to understand. This image was not so good, but I missed this information. I was looking the bifurcation, so I missed this haziness, and I performed the first part. But after a few minutes, the patient developed chest pain, acute chest pain, with sudden right arm movement and guiding catheter disengagement. So I lose both of the wire, not really both of the wire because one wire was removed. I lose the wire into the LAD. Patient developed ST elevation, lateral ST elevation with the hemodynamic instability due to acute stent thrombosis of the circuit, as you can see from this angio. This is the flow into the LAD, but the flow into the circ was completely missed. So at this point, the hemodynamic instability was followed by cardiac arrest. So we start immediately with cardiopulmonary resuscitation maneuvers. But the situation was not so easy to manage because I lose the wire, I lose the guiding catheter, and we have to manage very quickly this situation because the patient had also a chronic total occlusion of the RCA. So in this case, we can go on into the complication management, how we manage this situation. And then after the management of complication, we have to keep in mind that also the DK crash was not, all the step was not done. So we should always take in mind that we have to finish the step of the DK crash. So this was the situation that we were in front of acute instant thrombosis followed by sudden cardiac arrest. No wires in place in both arteries. We were using 6-trench right radial access, and so this is the first question for the panel of my friends, Muzaffar and Kambiz. So what should be the next step? I would like to have your feedback. I can hear you, Muzaffar. You are unmuted.
Yeah, sorry. Okay. So, okay, this is very complicated situation. So, first of all, I would like to have just one more access, the arterial access from the femoral approach, and then put some intra-aortic balloon pump maybe. Then, of course, we have to immediately cross the lesion and just dilated the LAD. Then crossing the circ. How about your comment, Kambiz?
Well, when I saw this scenario from the beginning, I was thinking about it in general, a different strategy, because this osteocirc stenosis have always a lot of recoil. So, and we have often a lot of eccentric calcification. Here it looked quite concentric, but I probably would have really rotablated this ostium circ. So if you don't have the rotablator, probably you can go for a cutting balloon, or you can make an IVUS imaging to understand did you crack the calcium or not. But even if you have a beautiful stent expansion with no recoil there, you still can have distally a dissection, right? And this dissection caused this tragedy. So now you're in a resuscitation situation. Is it correct?
Yeah. Is it?
This is the absolute nightmare.
Yeah.
So you have 6 French. You have to resuscitate the patient, and you have flow in the LED still, right?
Yeah.
So one more question for the technique. So in this kind of the ostial circ calcified lesions, so the DK crash is the correct technique, or using you prefer the culotte in order to covering all the circ area, including with the stent, and which is providing better stent expansion and the coverage of the lesion, the cambus. So when we think again the lesion, because when we use the DK crash, since the ostial, sometimes it cannot be possible to cover all the lesion with the stent, which is covering all the calcified the part of the circular part of the circular orifice.
Yeah, this is also what we don't know in the calcified ostial circ. If you mean if DK crush is better in this scenario.
So this is just my question for this one.
Gabriel, did you use IVUS in this intervention at the beginning?
Yeah. When I perform a left main PCI, I always use IVUS, but I usually use it after the delivery of the stent, just to understand the correct position of the stent. So it's not my routine practice to use IVUS before. Okay, if I have some doubt regarding the plaque distribution or the classification, I can use it IVUS just before stenting. But usually I use the IVUS after deployment of stent, just to be sure of correct position of the stent. So in this case, my plan, my strategy was to use IVUS after the DK crash technique, after the successful deployment of both of stent. And regarding this image, the stent was length 24, so it was not really a dissection at the distal edge of the stent, but I think a thrombosis, in-stent thrombosis, because the stent, this is the landing zone of the stent, and the edginess was in the mid part of the stent. I'm so sorry, because the image is not so good to run, but okay. Okay, so
it's a very difficult situation to
see.
Sorry, it's a very difficult situation to manage. Okay, I'm curious what you did.
Yes.
Okay,
Me too.
so we can go on.
Yes.
Yeah.
Are you
Yes.
okay? Yeah.
And maybe one more question from the audience, that the angle between the LAD and CX seems to be over 70 degrees. So does it affect your choice for DK crash strategies and preferences?
Not really, because as I said, in this left main bifurcation lesion, if I have to use a dual stent technique, nowadays my preferred strategy is DK crash. But this is my opinion, okay? So independently from the angle of the bifurcation, if I have to decide to perform as a first intention a dual stent strategy, I perform DK crash.
Okay.
Okay, thank you.
Okay. Oh, you're welcome. So this was the setting. The first operator, a doctor, the nurse is as a second operator, and then another nurse. And obviously we are in front of a cardiopulmonary resuscitation, so we need another nurse that was to perform the cardiac resuscitation. And then, first of all, we take a second access to advance quickly an intra-aortic balloon pump. This is the first and quickest strategy that we did. Okay. Then we we need the anesthetist to perform the intubation of the patient. So we call another doctor and another nurse. And finally, we decided to, after intra-aortic balloon pump advancement, we decided to use also the impeller system. So finally, we were 9 persons. This is all the staff that was that were involved in the complication management. 9 persons, 3 doctors, 4 doctors and 5 nurses. This was possible because this complication, this case, occurred during working hours. So in case of on call or during the night, it was not the same. So this is interesting because I show you the timing of the management of the complication. So the first image that we had of the instant thrombosis just a few seconds before few minutes before the cardiac arrest was taken about 10 a.m. And then in 7 minutes, we were able to start to advance the intra-aortic balloon pump. You can see here the balloon pump that was placed 8 minutes later. And then after 4 minutes, I was able to rewire the circ despite the cardiac arrest and despite we lost the guiding catheter. Then 7 minutes later, we take the third access because we were from right radial. Then we took a second access from right femoral, the third access for impeller system from the left femoral. 7 minutes later, we were advancing the Y to deploy the impeller system. And then after 7 minutes from the third access, we were able to advance the impeller system into the left ventricle. 8 minutes later, we achieved the ROSC. So 32 minutes later from the cardiac arrest, we achieve an hemodynamic stability with the restoration of the flow into the circ and into the LAD. At this point, we should go on with the final step of the decay crash, and then we should have been to be sure to a complete a resolution of the thrombosis, instant thrombosis of the last circumference. So we performed the final step of the decay crash, but also we advanced another stent into the mid part of the LAD. And finally, the final kissing balloon, followed by the final pot using a 4.5 balloon. And this was the final result after a final pot, after deployment of second stent into the mid part of the LAD. So we were exhausted. We finished the procedure after 3 hours, but we used very low dose of contrast media. And so this is our setting. And we decided for cangrelor, bolus during PCI, followed by crushed ticagrelor during the infusion because of instant thrombosis. So maybe due to clopidogrel resistance, and during the hospitalization, the patient underwent the test that confirmed resistance to clopidogrel. And this was the team approach. So 9 persons involved into the cath lab during this emergency, during this catastrophe, and 3 hours of procedure, 71 minutes of fluoroscopy. It's not so high. And this is a slope of the events and over time. So the resuscitation maneuver takes 32 minutes, no more. But to achieve a good outcome, we need to be 9 persons. So this is really a team-based approach to manage this complication. That, as I underline, it was possible because of working hours. It happened during working hours. So this is the picture that I take 2 weeks later with the patient that was discharged without any problem. And I have 3 questions for the panel. Should always unprotected left main PCI with concomitant RCA CTO be performed with a left ventricular support? If yes, which kind of support? So this is an open question for my friends.
Okay, Kambis. So of course, depend. So after having this information with this complication, so you would like to prepare all this left ventricular support device, Impella, and the others. But at this time, depends on the lesion characteristics and the proper evaluation of the lesion in advance. And so in this scenario, like this complicated case, the occluded RCA and a complicated calcified lesion of the left main and the circ, then we have to be alert for possible complications. So then we have to keep just in mind the requirement of these left ventricular support devices, intra-aortic balloon or Impella. But in this scenario, I will not start with Impella because the ejection fraction is not almost normal, so it's not requiring really left ventricular support in advance before starting the procedure. But of course, in case like you, we can require those supports, and at this time, those devices should be reachable. Both device and the personnel should be reachable on time in order to avoid and overcome those problematic situations. How about Kambis, your comment?
So I personally would not go with Impella directly in this case. So I would probably start like you, Gabriele. When I have a man, I go with a 7 French radial in these cases. But so the reason when I use Impella in left main or let's say in a good LV function is if I have a last remaining vessel situation to treat where I can't predict the outcome of this PCI. So which means that when I have a severe calcified long disease on the last remaining vessel, for example, circ occlusion, RCA occlusion, I really feel very comfortable if I have a support device in. It's a little bit different if you have patient with a severe MI and low ejection fraction and multi-vessel disease and calcification. And there sometimes the pressure, so pulmonary pressure and left ventricular interstitial pressure may help you making the decision if you are doing a protected PCI in advance or not. So, so if this patient would have an LV function of 25 and mitral regurgitation third, and for example an LVADP for 28 or 30, and probably also is on dialysis, I think this may, and the groins are okay, and you have a low risk for the puncture, I think then protection makes sense. But in this case, I would never do the protection, right? So I would start like you. Probably in 7 French, the strategy would be a little bit different. Probably I tried to make a plug modification with the rota, but this is up to everybody, right?
Yes, yeah. I completely agree. Just for the 7 French, guiding catheter will be more comfortable if we require some rota and the other things. But remaining, of course, I will also start like you with the radial approach, of course, at the same time.
Yeah. So the next question, okay, we can discuss both of them. 6 French, we already discussed it. Should the 6 French transradial access be considered suitable for unprotected left main treatment, and should DK crash be considered the preferred strategy? So we already discussed it. I don't know if you want to add some other comments regarding the last of 2 questions.
The question is, what did we learn here? So what is the take-home message, Gabriele, for yourself the next time? So because this is really by coincidence, right? That you have a distal dissection is really, I mean, it happens. It's really bullshit. Yeah. So it's not that you did something wrong, right? And the platelet activity, I think, was also okay. So the patient was uploaded in front. So it was really by really bad chance for the patient, right?
Yeah, I think that in this case, the complication that I had was not due to the sixth French, or not due to the technique. I mean, I had an instant thrombosis, and it's not related to the technique. Maybe could be related to the sixth French, because sometimes if you advance to several devices inside a sixth French, like in this case a balloon and stent, you can have a guiding catheter thrombosis. So in this case, you can move a thrombus inside the artery. But it seems that it was not the reason of instant thrombosis. But if I have to reconsider this procedure, maybe next time I can decide to use the sixth French, not really to avoid this complication, but just to have more chance to advance the technique in case of need.
Mm-hmm.
Okay. Göksel, do we have any questions?
Yes, I have one other question is there an opportunity in your center for the ECMO in this so extracorporative life support during resuscitation? Because here I saw a little bit different approach than in our center when the patient crashed. So I think it was very interesting how you treated. You were very fast. But we normally go for the extracorporative life support in this scenario. In resuscitation, when we have a technical problem, we try to make the ECMO, because the 5-liter flow is sometimes really a little bit better than the 3.5.
Yeah, in my hospital, it's available ECMO. We have the team, dedicated ECMO team, and we already use it in other complications or in out hospital cardiac arrest. But this is not the first strategy in this kind of situation. We try to, the quickest way is to advance the balloon and then the impella. In case of failure of impella, we call the surgery for the ECMO. They went, they arrived into the cath lab, they were ready to go on with the ECMO, but finally it was not necessary, fortunately, because of the restoration of circulation.
And Gabriele, may I ask you another question? Is when you have impeller and ECMO and balloon pump in the room, right? And you have a patient who crashed with an occluded RCA, and now the circuit is occluded also. Why invest the time for the intra-aortic balloon pump? Why not directly go for the impeller and then, if you need, on top, put the balloon pump?
Yeah. But we didn't lose time. I mean, to deploy impeller, impeller deployment takes more time than intra-aortic balloon, because you have to call for a nurse, then we have to prepare the impeller system, and the most quick device as a first strategy, it was the intra-aortic balloon pump, while the nurses were preparing the impeller to be advanced. And then I call another physician to take the third access.
Okay.
And it was as a over time with a unique aim. Our aim was to advance the impeller, but in order not to lose time, we advanced the intra-aortic balloon, and then other doctor was taking the third access, and the nurses were preparing the impeller system.
Okay. And actually, as a cardiologist, we just used to first time using the intra-aortic balloon pump, then we are thinking the others. So maybe we can thinking at this time to overcome the problem immediately, and the balloon pump will be enough. But in this case, in this scenario, of course we need a like Impella and
Yeah.
or maybe ECMO in this situation, in this scenario?
I perfectly know that probably in such scenario, the intra-aortic balloon pump was completely ineffective.
That's
But
true.
it was the quickest solution waiting for the Impella.
Okay.
And then the Impella waiting for the ECMO. Finally, when the ECMO team was ready, we achieved restoration and hemodynamic stability.
Okay, great.
Okay, thank you, Gabriella.
Oh, you're welcome.
Great.
It was excellent. So now we don't want to make lose much more time, and the screen is going to the Cambis for the another case.
Okay. So I would like to talk a little bit about the actually also about the situation, about the pandemic situation, and also about what happened actually, what happened to us and to our patients, and probably want to have a little bit of critical point of view on the collateral damage, on the complete shutdown and the stay-at-home message. I mean, for sure, there are several pandemic regions worldwide, and I know the Lombardia was a catastrophic. But it was interesting also to see what happened in other countries where they had not such a severe scenario, and what happened. And I will want to tell us his story about this, what happened to us or to me during this COVID-19. So just to explain you where I'm working and what was the situation in the institution where I'm working, and I'm at a university hospital in Freiburg and Bad Krozingen. So there are two centers, and I'm working in the big Hut center, and with 310 beds, and there are about 27,000 outpatient patients and 70,000 inpatient patients. Those two centers are 15 kilometers away and are combined in a big university heart center. We have the two cardiology departments, pediatric department, heart surgery, and so everything is there, what you can imagine. And yeah, here you see in total a lot of patients, right? 21,000 in-hospital patients, 47,000 outpatients in total of the heart center, and more than 1,600 employees, 260 doctors and 680 nurses. So in our center, there are a lot of also facilities for labs, in total 15 cath labs with 4 hybrid labs and 11 labs in Bad Krozingen. So this is how it looked like, and in the last 5 years, we performed about 16,000 PCIs, and this is a rather small area. It's not like Istanbul, where there are 50 million people. Here, there live about 20,000 people, and there's a town, Freiburg, there are 250,000 people. So the most patients are coming to us because they are referred to our center. And in Freiburg, there are a lot of acute coronary syndrome patients. They make also additionally 1,500 PCIs. And so about 7,000 PCIs in the 5 years. So the total volume is about 23,000 PCIs in the last 5 years. And I have a huge CTO program here, which has also huge numbers, over 500 to 600 CTOs per year, which are treated by my team. So the patients are coming from everywhere. And why I'm telling you this is because on the day where we decided that we had to stop actually our elective program, I had a waiting list of 45 elective CTOs, which were already planned from March the 16th to 21 of July. So about 5-6 weeks. There were 45 elective patients, and so I started with an Excel sheet and started which patient is more at risk than the other patient, right? So because I had to decide which of those patients can be postponed and which of this patient may be at risk once they are postponed. So those were the screening list, and the green markers were those patients where I said, as soon as we start the program again, we have to deal with them. So, well, we already talked about this strategy. So what to do in the acute coronary syndrome. I think due to sake of time, I would just go over it, how our internal SOPs are. And I want to go to some slides about the stay-at-home message and what happened to patients actually and people out in Europe and also US. So I think there was a strong recommendation to stay at home and to do the shutdown, and it may provide many infections. That might be correct. But just to see, this is the public health database from England where everybody can look at it, and this is what happened to people and once they come to the emergency department. And you can see that in February and March, actually, there was a huge decrease of numbers of patients coming to the emergency departments. And here you see the patients with the myocardial ischemia, so acute coronary syndromes, which were just completely reduced in this time where we had to stay at home, where there was a complete shutdown and social distancing. And also now it's pre-approved in Czech. Also in US, in areas, we could see that the acute coronary syndrome were reduced dramatically before and after COVID, as you can see here in 2019. STEMI activity per month per site before COVID and after COVID. So less STEMIs were going in the emergency departments. And here you also see the drop of the STEMI patient actually in March, as you can see. So this you could also see here where you see the declines in hospitalization for acute cardiovascular conditions, which just dropped down in March due to the stay-at-home message, the decline of 5.9% per day in any cardiovascular, so stroke, coronary, and congestive heart failure. There was a decline in Massachusetts. It was over 7,000 patients were compared to the year before. And this also showed, and numerically it was not absolutely significant increase of in-hospital mortality of those who were admitted at the hospital, as you can see here. So the p-value was 0.606, so 6.2% of patients died in comparison to January 19 to February 20, 3.8 patients died to cardiovascular mortality. And we have great data from Italy, and I want really to thank the Italian colleagues about that, because it's very important. So here you see in the New England Journal of Medicine that you had in the study period, which was from the 20th February to the 31 March, you see all acute coronary syndromes, and so which were admitted in the hospitals. And here you have the control group, two control groups. One was from the 1st January to the 19th of February 2020, and one control group was from the 20th of February to the 31 of March in 2019. And we could see a significant reduction of acute coronary syndromes in our emergency departments. Probably one of the most beautiful slides is this one, which was published in the European Heart Journal on the 15th of May, where you can see also from Italy that there was a decline in acute myocardial infarction of 48%, and so also a decline of STEMIs of 26% and non-STEMIs of 65%. And here you can see the mortality actually. The mortality was increasing dramatically from 2.8 to 9.7%, for the STEMIs from 4.1 to 13.7%. And this is a huge problem. So, because the people were afraid to go to the hospitals, and therefore they died, and we know that there are more resuscitation, and once they came to the institution, they were much more sicker in a severe, worse condition. And even also from Spain, we had also some conversation with Javier Scanet, and so the same we could see in this publication, more ventricle septum defects, so more major complication have been seen in the past, life-threatening arrhythmias and severe mitral regurgitation in the past. So in our lab, we are doing every day about 50 to 60 CAFs, peripheral, coronary, and every day I see 1, 2, 3 patients with a subtotal stenosis of the left main, LAD, RCA, and proximal LAD. And those patients did not come to our institution. The number of people who died in Freiburg area is a little bit higher than last year. And everybody is believing that it's due to COVID. But at least in our area, I'm very skeptical about that. So, because we have a lot of patients like this. This patient was a lady, and she has even a private insurance, and she's 78 years old, and she's a CC-free and NUHA-free symptomatic since 2 months, and the LV function was 37%. She was sitting at home, couldn't move anymore because severe angina, and just sitting at home for 2 months because we couldn't do a CAF. We had a lockdown here. She couldn't go to the doctor because everybody said it's dangerous at the moment, even if our institution didn't have many COVID patients at all. So she was easy to treat. But I'm not sure how many of these patients did not reach the hospital, right? The same 82-year-old male. So we have these cases now every day, multiple times. With 6 weeks severe angina, CC-free classification. So also here, he didn't move at home. He had angina all the day. He had also no doctor where he could go, and this is how he came to us. Well, it was easy to treat again with culotte technique. And now I come to the CTO patient, and which we postponed. And this guy came due to some consciousness, so he had some syncopes. And this was a patient, 61-year-old, a male, CCS-free angina, and he was a surgical turndown because he had already grafts, and the grafts already failed. He has a diabetes mellitus 2. Ejection fraction of 34%, and the MRI showed a subendocardial anterior scar apical mid-ventricular. So, well, the surgeon saw the patient a couple of weeks ago before the COVID pandemic, and they said, well, we cannot do again surgery here due to no material or something, or at least they refused him. So this, in another hospital, they tried to reopen him here at the vessels, and they failed to reopen the RCA. So, and also the LAD. So the patient had some consciousness, syncopes at home, and severe angina. So I had to treat the patient now because it was one of the first patients which I started to treat when he came back, when we tried to go back to normal. So the problem here was first how to start. So as you can see, there is the LAD occlusion, there are stents in the circ, there's a subtotal stenosis of the circ, a distal of the stent, and there's the RCA. And probably we can just make a short, short stop and discuss how to start here and what to do. Should we put this patient on protection? Should we go for antegrade escalation, which is already failed? I think 1 or 2 times. They also tried to open the graft to the RCA also. Should we try to go retrograde? And so I want to ask my friends who are doing also CTO, so Gabriele and Mustafa, what's your opinion to this patient? How could we help him?
Yeah. Yeah, it's not so easy. Just I missed one information. What about the graft on the LAD? Was already patent or not?
It's occluded. So all grafts are occluded.
Oh, okay. Yeah. Okay.
Yes,
So
information which I didn't give you is here's also a lupus erythematosus, and well, the renal function was not too bad, about 45 GFR.
okay, maybe looking this angio, the first strategy could have been to start to reopen the right coronary artery.
Yes.
But it seems, but you know very well that it's not really simple. So it seems more simple than LAD CTO. So maybe my strategy could have been to start with a RCI CTO. Antegradely, I don't suggest to reopen the graft, because when you have the opportunity to reopen the native coronary artery, it's better than reopen the occluded graft.
Yes, yes. Well, Mustafa, do you want to comment? Mustafa, you have to, your signal, we can't hear you.
Okay, so I think just when we look at the baseline angiography, just the one touchable, the more easy touchable lesion looks like RCA. Okay, but already it's failed. This is also another situation. And also I would like to come back to the LV support. So do you also plan to have just keeping some LV support device or access, even for the access before the procedure?
So I didn't plan it. Yes, and retrospectively, I think it would have been good to do it, but I didn't do it.
Okay, so okay, we are waiting for approach.
Yes, for sure. So for sure, you are all above. You are right. Yes. So so right. There is no wrong, right or wrong, but this the more simple, and also for me, the more simple look. Definitely the RCA, because I had said maybe I have some wire escalation chance. But here you can see the wire is already in the side branch. But the puncture towards the first island here with the wire, I already failed. I couldn't get the wire punctured to this island, which you can see here. So even with the dual lumen microcatheter and Sasuke, there was some calcium here. And I always, the wire went out somewhere. So I had a problem. And so I thought maybe if I could get a good puncture, probably I can get a polymer after the puncture, polymer check it wire and knuckle a little bit down and go to retrograde and make a reverse card or something like that. But I had really problems with the correct puncture of the proximal part already. And therefore, after this, I said, well, there is a septal opportunity. For sure, you need another REO. I know this, but I don't know if I have it. But I went retrograde. I show you the next slide. And it was not complicated to go here retrogradely. I went into the PDA. And in the PDA, I wanted to analyze my distal landing zone. And I did deep injection. And once I did the deep injection, the patient gets to VT and VF and was already a rhythm where we had to shock him, right? So, and I didn't realize what was the reason, but it was for sure the ischemia. Yeah. Because I had the subtotal circ problem. With my microcatheter, I occluded the bifurcation to the diagonal. And the diagonal gave support to the distal LAD.
Yeah.
And I occluded with the septal connection, I occluded almost the posterolateral branch. So the patient was going in a disaster right now. So so we had to give him vasopressors and catecholamine, so adrenaline and everything, and also Quadarex. But in total, in this area, he had 19 shocks. So 9 shocks. So what I did, actually then was I retrieved my microcatheter. I let the wire distally. I retrieved my microcatheter apart from the uptake of the diagonal. And then tried somehow to modify the antegrade cap and failed again. Then the anesthesiologist said immediately, you know, we have to intubate him. And I said, okay, the pressure was stable. And after the intubation, I tried to advance again the microcatheter, and the Coderex was already inside, so 600, 300. And he surprisingly stopped with the VT, recurrent VTs. And I could manage to get the retrograde microcatheter up. And there I tried to puncture up, but always ended up in the graft. So finally I could find a route, a little bit lucky, where I went towards the antegrade cap. And there I could do, then I had the retrograde marker wire, and I punctured with a stiff wire towards the retrograde marker wire. I knuckled a little bit down and could do the reverse cart there. So after reverse cart and externalization, I could bring a dual lumen microcatheter down and could engage the posterolateral, which was a big posterolateral branch, and I could fix the RCA. So at this moment, I was happy because the RCA was open. And my colleague who is doing, Mohammed Ayub, who is doing a lot of CTOs with me, he encouraged me to go on. He said, Kamis, now we have already, the patient is intubated. He had a high arrhythmogenic risk, and probably this is a good option now to go on. So I was first of all, I was skeptical, but then I said, okay, maybe reasonable. We probably could reduce the major problem of the ischemic risk now. And actually, so we decided to go on. And the wire, so here you can also discuss of antegrade wiring, parallel wiring. I had also a comment on the question on parallel wiring here. But the landing zone is very small, and which means that the likelihood to get the wire antegrated down is there, but or also to do an ADR is there. But if you have a very, very easily retrograde access like here, so I had to stand the diagonal, as you can see, and so I could very nicely go retrograde. I had the retrograde wire there, and then it was not complicated to get the antegrade wire, to get the antegrade wire, I don't know why it doesn't run, to get the antegrade wire towards the retrograde. So it was a kissing wire technique. And after this, I could stand the LAD, and it was a very, very big LAD. So this is the LAD and the RCA now opened, and I still had to treat the circ, subtotal. I did this also. And so now we said, still there's a subtotal stenosis on the diagonal. And I tried to make the final kissing, but the antegrade wiring failed. And here you see the beautiful collateral retrograde, which we used. And it was very easy to get a workhorse wire through it and wire it retrogradely. And here you can see that the retrograde wire and an antegrade microcatheter. So I put a retrograde wire into the antegrade microcatheter, and then I could just bring the antegrade microcatheter over the bifurcation, exchange it to an antegrade wire, did my final kiss, and the patient was okay. So this were the 3 patients which we were treating relatively directly after the lockdown, when we started again with our elective program. And I think all 3 patients were at a very, very high risk. And these are the patients, at least, that we see. And those we don't see, some of them may probably gone already to heaven. So, Gabriele, I know you have also a very beautiful meeting on the TOVI this year, and I want also to announce the MLCTO meeting. It would be great if we can have you there, but we can't meet each other in Nice like we do all the time at the moment. but we can meet on web. And it would be the 3rd and 4th September. We will do live cases for you from Paris and also from Belfast and maybe also from Canada. And we'll share some great cases over the last years. So this will be an online edition. And hopefully, I don't know, but it would be great if we can meet each other. And still, we have the hope that it's possible in Berlin again for the EuroCTO Club meeting. It's also in September 11 and 12. So we have to cross the fingers that it's possible to meet each other again and drink a beer in the bar, despite the COVID pandemic. Thank you very much.
Congratulations. Extremely difficult case. Performed very successfully. And in this COVID pandemic period, of course, those cases cannot wait more longer. And then we have to treat those patients. And the surgery, of course, will turn down from the surgery, those cases, and they are requiring immediate treatment. And your observation, and all countries have the same observation, the number of patients admitted to the emergency department for the acute coronary syndrome is going down almost more than 50%. Also in Turkey, we have the same observation. And the patients are coming very late, and we observe much cases with higher thrombotic lesions, and the treatment of those cases is getting more difficult. So how about your comments, Gabriele?
Yeah, I have. Okay, first of all, congratulations. It was a very great case, but it's a Cambis case. So, no, the message is it was a great procedure. It's not a procedure for all the operators and not for all CTO operators. You should have a great experience like Cambis, because this patient was very fragile due to the failure of the previous surgery, and then low ejection fraction, and maybe also because it was quite old. I don't remember exactly the age, about 80,
61 years.
So young patient. Okay, and then in this case, the strategy to go on after the successful RCA, CTO, PCI was correct, because this procedure was done by a very expert operator, and in this case the patient need the best strategy in order to achieve a complete revascularization. So in this case was a very great decision, and with a very great final result. But the complication that you observed, the ischemia, due to the ischemia of the donor vessel, not really the donor vessel, but due to the advancement of the retrograde gear, it's a complication that you have to consider when you perform CTO PCI, and you have also to understand, like Cambis did, to understand what was the problem, because sometimes if you don't realize the problem that create the complication, you are not able to go on if you have this possibility. So congratulations, it was a great case, but it's a case just for very, very expert operator, and as all of you know, Cambis is one of the best operator all around the world, and I think that the first one of the second with Alexander in terms of number 4 years. So congratulations. The second thing, it's a question for you, Cambis, regarding the data that you show, that I know very well, in terms of dramatic drop in number of hospital admission for STEMI or ACS. But what do you think about the next future? Do you think that we can observe an increase in the number of CTO that we will discover for the first time due to the fear to go to the hospital? So a lot of patients experience a myocardial infarction at home. Some patient died, and some other developed CTO. So we are evaluating to to study the incidence of new CTO in the next 3 months compared to the same period of the last year, because I think that we will observe an improvement, increase in the number of new CTO. What's your opinion?
Yeah. Also, companies ask me this question also regarding the planning of their the whole economic situation. So what I can tell you is what happens is that more patients are coming with occlusions which are subtotal or subacute. Sorry, it's wrong. They have already collaterals, but very easy to open. Yeah, so they had 2 or 3 weeks ago, they had some angina, and probably the donor vessel, there's also some problems, and you just go and you have, even in those vessels, sometimes some, even if there is some viability still, there you have some old thrombus burden, so you may end up even in slow flow after these procedures, which is very uncommon for CTOs, right? Because a lot of sludge end. So this we will maybe see a little bit more, because the stenosis, the subtotal which we treated, are now turning into occlusions and are probably often easy to treat with antegrade vasculation. In generally, I'm not sure if we are going to treat more CTOs than last year from up to now. Even if there are more patients, theoretically more patients, there is the problem, and what I can see now is I get everyday patients, but the cath labs at the moment are not doing so many caths. Still not. They're still reduced. It's still reduced. So therefore, it's a tertiary center which gets referred cases. It's still, I think, a little bit less. Still, we have a lot to do because we have to treat all the postponed patients, right? So, and then this is the first, let's say, 3 months. Afterwards, I'm not sure if there will be an economical issue in healthcare systems and complex PCI, because the money for CABG and surgery, it's relatively clear. You need an oxygenator and 2 hands and stitches. But the money for complex PCI sometimes in many countries is much more higher. People have to pay. If they can't pay, if they lose their job, if you have really an economical going down, the crash, which may happen, and also there will be maybe less money for the insurance system. Probably not in Lombardy, probably not in Germany, but overall, worldwide, it may happen. So therefore, I think it will be a little bit back for complex PCI. I don't hope so, but I think we really have to encourage people to go on with complex PCI.
Yeah, absolutely.
Yes, I agree with Kambis. I think the number of CTO cases, maybe for the waiting list for 2-3 months, coming 3 months, will increase if we start regularly to the procedures. But the number of referral patients will go down. And also, this pandemic, I think, will not increase the number of CTO, will increase the complication, which is affecting worstly the LV function, or like you showed that some complicated dysfunction patients, the number of patients will increase instead of increasing the CTO. So, but of course, the economic situation of I think even developed countries like Germany, Italy, or United States, we have some unpredictable situation for the coming 6 months and the end of this year, how this economic situation will go, even the crisis, or just will recover properly, better than we expect. We will see, but we have to see the end of this summer. Okay, yes. Do you have any contribution, Arturo?
Yeah, I want to thanks a lot both to Kambis and Gabriela for their fantastic presentations and fantastic cases. Of course, I think people a little bit misunderstood the stay-at-home message. Therefore, many didn't come to hospital even for urgent cases. So I agree with you. In the coming months, we will see much more complication, much more electrically unstable patients, much more LV heart failure patients due to LV dysfunction. And of course, we can see much more complex PCI patients, complex anatomical patients. When we start the routine practice, our routine. But I think it will not be easy to turn our routine practice like last year. I think it will take some time to gain our routine practice. It will not be easy.
Mm. Yes, that's true. Okay. I would like to just finalize the session, the webinar. Thank you for everybody for their contribution, for the attendees, and for the excellent cases. We are going to share our experience with the webinars, but whenever we have an opportunity meeting each other in the meetings, the real meetings that we used to live, then we hope soon we will be together. And thank you everybody for their time and their contribution. Thank you. And I would like to speak a little in Turkish. Bizi bütün takip eden arkadaşlarıma da çok teşekkür ediyorum. Umarım hepiniz güzel bizimle vakit geçirmişsinizdir. Bu toplantıda hepinize katkı sağlamıştır. Bu toplantılara gene devam edeceğimizi düşünüyorum. Hepinize saygılar sunuyorum. İyi akşamlar diliyorum. İyi hafta sonları. Okay, have a good weekend everybody.
Thank you.
Thank you. Bye.
Thank you too, Muzaffer. Thank you very much.
Thank you. Bye.
Bye, Candice.
Bye, Gabriel.